In this video lecture, we'll discuss treatment options for bipolar disorder, including pharmacological treatment options, as well as psychotherapy. We'll start by talking about pharmacological treatment options for bipolar disorder. The primary pharmacological treatment for bipolar disorder is a group of medications called mood stabilizers. The most widely prescribed mood stabilizer is lithium, or lithium carbonate. This is an element, so if you've taken chemistry and looked at the periodic table, you've got hydrogen, helium, lithium, beryllium. That's this lithium. So lithium is an effective mood stabilizer. Approximately 50% of individuals will respond to lithium, and about a third will achieve sustained remission. However, lithium can have some significant side effects. Weight gain is one of the side effects of lithium treatment that many patients find most distressing. And patients also need to be monitored for potential lithium toxicity. There's a narrow therapeutic range in which an individual is receiving enough lithium to have it affect their symptoms, but not so much that they are experiencing potential toxic effects, which requires regular blood work that many patients find either difficult to adhere to or unpleasant. So another group of mood stabilizers are anticonvulsants or anti-seizure medications. So these are medications that were not necessarily developed in order to be psychopharmacological treatments. Many of them are treatments for seizures or other neurological disorders, but they also have mood stabilizing effects. These medications are also effective for treating both mania and depression in the context of bipolar disorder. So they are also widely prescribed for the treatment of mood symptoms among individuals either presenting with manic or hypomanic symptoms, or individuals with depressive symptoms with a history of mania or hypomania. There are other medications that are sometimes prescribed either as adjunctive treatments or in addition to a mood stabilizer, or that are sometimes prescribed instead of the mood stabilizers. These include atypical antipsychotic medications. We'll talk more about what these drugs are and how they work when we talk about psychotic disorders. However, one characteristic of the atypical antipsychotics is that they tend to be relatively sedating. So particularly in the context of mania or hypomania, or during a manic episode in which an individual is experiencing psychotic symptoms, atypical antipsychotics may be used as the primary treatment for mood symptoms, or may be used as an adjunctive treatment in addition to a mood stabilizer. We sometimes use antidepressant medication to treat residual depressive symptoms that are not responding to mood stabilizers, psychotherapy, or to other treatments. However, we need to be very careful when using antidepressant medication in individuals with a history of mania or hypomania, or even in individuals who have not experienced an episode of mania or hypomania themselves, but who have a family history of bipolar disorder that suggests that they might be at risk for experiencing an episode of mania or hypomania. In some individuals with a vulnerability to bipolar disorder, antidepressant medication may actually precipitate the onset of a manic or a hypomanic episode. So if an individual with bipolar disorder is experiencing significant depressive symptoms that are not responding to other treatments, they may use antidepressant medication, but they would need to be very closely monitored in order to ensure that they were not beginning to develop symptoms of mania or hypomania. When we look at the efficacy of lithium for bipolar disorder, it tends to be a very effective treatment. So as I said, about 50% of individuals will respond to lithium, meaning that their symptoms are reduced by at least 50%, and about 1/3 will achieve sustained remission. The greatest challenge we have with lithium treatment is treatment compliance. Many individuals with bipolar disorder, once their mood symptoms stabilize, will go off of their medication. And when we look at the experience of recurrence after an individual discontinues lithium treatment, you can see that nearly 90% of individuals who discontinue lithium treatment will experience a subsequent mood episode within 5 years of discontinuation. And actually the majority of those episodes recur very quickly. So if you look at that little zoomed in box, you can see that over 50% of individuals who discontinue lithium treatment will experience a recurrence within 5 months of discontinuing their lithium treatment. So lithium is an effective treatment for bipolar disorder. However, it's important for individuals to be maintained on lithium even after their mood symptoms resolve. We also have a range of options for psychotherapy for bipolar disorder. So when we are using psychotherapy to treat bipolar disorder, we are typically using it in conjunction with pharmacological treatment with lithium or with another mood stabilizer. And our goals for psychotherapy for bipolar disorder are psychoeducation, so helping people understand their disorder and helping them manage their risk for subsequent mood episodes, and also relapse prevention, so helping decrease the likelihood of subsequent mood episodes. And an important part of that treatment goal is often maintaining medication compliance, so addressing people's desire to go off of medication when they're no longer experiencing symptoms to help reduce the likelihood that they are going to experience a recurrence if they discontinue medication treatment. We have a wide range of empirically supported therapies for bipolar disorder. These include cognitive behavioral therapy, family-focused therapy, and interpersonal and social rhythm therapy. So I am going to focus on the latter two and tell you a little bit about them. So family-focused therapy is a family-based treatment for individuals with bipolar disorder. And the goal of family-focused therapy is not to address the symptoms of mania or hypomania, but rather to increase long-term positive outcomes. So to increase quality of life and to decrease the likelihood that an individual will experience subsequent mood episodes. Family-focused therapy has several components. These include psychoeducation for both the patient and their family about bipolar disorder, so what the signs of bipolar disorder are and what the symptoms are. An important component of this for families can be understanding the person's behavior and how behaviors that they may have engaged in during perhaps a manic episode are symptoms of a disorder, because individuals with bipolar disorder during manic episodes can sometimes engage in behaviors that cause a high degree of family conflict or that lead to conflict or distress within the family. So helping family members understand that sometimes when their family members have been engaging in behaviors that are upsetting or difficult to understand, recognizing the link between the disorder and those symptoms. Another important component of psychoeducation is helping the patient and their family understand the vulnerability stress model, so to help them think about periods of increased stress that might be greater risk for recurrence, and to help families and patients develop relapse prevention strategies. Family-focused therapy also addresses communication within the family to improve communication. This includes working with patients and their family members on skills including active listening, delivering feedback effectively, and effectively requesting changes to behaviors. And it also involves problem-solving skills training, so helping all members of the family identify interpersonal problems that are happening within the family, and helping them select and implement effective solutions to address these interpersonal problems. To look at the efficacy of family-focused therapy, I'm going to present you with results from a study of 53 patients with bipolar I disorder, all of whom began this treatment shortly after being hospitalized for an episode of mania. And throughout this treatment, all of them were maintained on medication. So in this study, we are comparing a group of patients who received medication and also engaged in family-focused therapy, and another group who received medication who did not get family-focused therapy. So we call that the clinical management group. So I mentioned earlier that these psychotherapy treatments are not meant to treat acute symptoms. So family-focused therapy did not result in any significant differences in individuals' acute symptoms of mania or hypomania. However, when we look at long-term outcomes, we see significantly better outcomes in the group of patients who received family-focused therapy. So in this figure, we are looking at the proportion of individuals who did not experience a subsequent mood episode over the follow-up period. So you can see that they were followed for over 2 years, and about 70% of the individuals who received family-focused therapy did not experience a subsequent mood episode over the 2-year follow-up period, compared to only about 30% of participants in the clinical management group did not experience a subsequent mood episode. So family-focused therapy is not an acute treatment. It's not going to address immediate symptoms of mania or hypomania. But for individuals who are on a mood stabilizer for bipolar disorder, so on lithium or another one of those mood stabilizers, family-focused therapy can help decrease the likelihood of recurrence or relapse and can also improve quality of life. Another psychotherapeutic treatment is interpersonal and social rhythm therapy. This treatment combines several different elements. So it includes interpersonal strategies similar to what we saw in family-focused therapy, particularly addressing improving patients' relationships and enhancing communication. So one of the goals here is to decrease stress by helping people engage in their interpersonal relationships more effectively to reduce interpersonal stressors. And it also includes a significant element of behavioral strategies. So these include self-monitoring to identify potential onset of symptoms early, maintaining routines, because disruptions in routines, particularly schedule-related routines, things like when a person goes to sleep, when they wake up, or major elements of their day, like when they go to school or when they go to work. Disruptions in those regular routines can sometimes precipitate the onset of a mood episode. So an important part of these behavioral strategies can be maintaining routines. For example, maintaining a stable time to go to bed and a time to wake up. And another one of these behavioral strategies is helping people identify and cope with stressors to reduce the likelihood that these stressful events will precipitate a mood episode. So here you can see the kind of log that might be used in interpersonal and social rhythm therapy. You can see that this patient is tracking several specific behaviors. They are looking at when they take an afternoon nap and when they have dinner, and over the course of a week they are tracking whether or not they engage in those behaviors and when they're engaging in those behaviors. And in therapy they may use that to identify the relationship between those behaviors and their mood, to keep track of whether they are keeping a regular time for those behaviors. And also tracking these behaviors can help the patient and the therapist identify some early evidence of potential onset of symptoms. For example, if they notice any major changes in the timing or frequency of specific behaviors. So here I'm going to show you results from a study of 175 patients with bipolar disorder who received interpersonal and social rhythm therapy. And like the previous study, all of the individuals in this study are also receiving medication. So they are all also on a mood stabilizer. Interpersonal and social rhythm therapy is an adjunctive treatment that's used in combination with pharmacological treatment. So when we look at results in the acute phase of treatment, similar to what we saw with family-focused therapy, there was no difference in symptom levels between the group of patients who received interpersonal and social rhythm therapy compared to a control group that received clinical management for their medication. The average time to stabilization in both groups was about 18.7 weeks, and there was no difference in the length of time it took for an individual's mood symptoms to stabilize. And there was also no difference in the proportion of patients in the two groups who achieved remission on their medication. So about 70% of participants in both groups achieved remission from their symptoms with the mood stabilizing medication. However, we do see differences emerge during the maintenance phase. The average time to recurrence was shorter for participants who received clinical management compared to those who received interpersonal and social rhythm therapy. So if an individual did experience a recurrence, it tended to occur more quickly if they had not received the therapy. And the proportion of patients who experienced a relapse within 2 years was significantly higher in the clinical management group. So these numbers don't look very different, but statistically there was a significant difference between the two groups, that the group of patients receiving clinical management, so on medication without psychotherapy, were more likely to relapse and have a subsequent mood episode within 2 years compared to the participants in the study who received interpersonal and social rhythm therapy in addition to the medication. So similar to what we saw with family-focused therapy, IPSRT is not a treatment for acute symptoms of mania or hypomania in the context of bipolar disorder. However, both of these psychotherapeutic treatments appear to be effective in the maintenance of individuals with bipolar disorder as an adjunctive treatment in combination with medication.